Thank you for being with us, and it's my pleasure to introduce you here in Egyptian Vascular Club. You will present one case about branched TVAR for residual type A aortic dissection. You can start.
Let me see. Can you see my this?
Yes, we see it. You see it clearly.
Very good. As always, Ahmed, when you're involved, the technical aspects of a meeting go very well. Thank you for the invitation, and thanks to all the other organizers for having us. So I have to apologize because in this presentation, there is not one case, but I have a case of chronic type A dissection that is treated by branched TVAR, but I don't have a really edited video. So let me show you this case and then see whether we have time to show an edited case that is, which is actually a 3-branched arch TVAR, but not a dissection case. And Ahmed, please stop me if I go over time. So this current case is a 50-year-old male who has a large false lumen aneurysm, very typical as a residual dissection, as you see on the right-hand image. You see that the arch vessels are all dissected, which makes both endovascular and open repair challenging. As the patient declined open repair, we planned him for a 3-branched endograft, landing in the ascending replaced aorta, and also including seal down to the celiac artery, including false lumen occlusion using a 2nd-generation candy plug. This is the first angiography showing you the ascending repair, providing a relatively nice landing zone. And you see the large false lumen aneurysm, the proximal descending thoracic aorta. This is the 3-branch device, which is already put into place and positioned according to the ostia of the arch vessels. Here you see, after the 1st branch has already been deployed, the connection to the 2nd branch, which is for the left common carotid artery. In this challenging case, we had actually to knickerbocker the carotid artery in order to get a seal. So that was the aim, at least. And the left subclavian artery was also dissected. This is why this patient received not 1 vascular Amplatzer plug, but 2 vascular Amplatzer plug in the 2 different lumens of the left subclavian artery. And you see that there is still space at the side of it. This is then already the final angiography showing good perfusion of the arch vessels, including the bypass. I'm sorry, I said 3-branch TVAR is the edited case. I will show you in a minute. This was a 2-branched case, including a bypass from the common carotid artery to the left subclavian artery. And already there we could see that we could not achieve seal in the innominate artery with the device, as it also was dissected. So a number of challenges here, but usually as we do large surgeries, it's often a good idea to take a break and stop. And this procedure was stopped after 5 hours of treatment with a reasonable dose area product, as you see here. The patient was extubated in the OR and spent 2 days on the intermediate care unit and was discharged after 6 days. He had no complications, but the post-op CT, as you can see here, showed, as expected, a type 1A and B endoleak. After 6 months, a follow-up CT was performed, showing that the endoleak had not resolved, both the type 1A and type 1B. So the patient was taken to OR again, and we used the access to the false lumen, passing the candy plug that you see here, and identifying contributors to the endoleak, which included some intercostal arteries, which were coil embolized, as you see here, by the cords in the intercostal arteries. Furthermore, we noticed that there was false lumen flow in the common carotid artery which was dissected, and that was treated with additional coil embolization as well as the innominate artery. Additional intercostal arteries that you see here were also accessed and coil embolized in order to reduce the false lumen flow, as you see here. So there was an extensive embolization session with a good result and no upwards perfusion at the end. Here you already see the 4-year follow-up images showing that the aneurysm stayed at a stable diameter. There was no further endoleak, and you can see from the distal part that the false lumen has also regressed somewhat, and the true lumen has expanded. So that is a typical case in a chronic type A dissection. Let's see if we manage to show you also some moving images. This is of a 77-year-old patient with a thoracoabdominal aneurysm, which receives as a first stage a 3-branched endograft in the arch, as there is no suitable sealing zone in the transverse arch. This is the device with 2 antegrade and 1 retrograde branch for the LSA, and a reverse tapered endograft to achieve some staging result by occluding some intercostal arteries. As a preparation, we have an access from the right common carotid artery and the right common femoral artery. Here you already see the main device introduced using a CT fusion from Philips, which is called Vessel Navigator, which allows us to position the device according to the markers in a way that the ostia are in an optimal position for catheterizing the branches. Using IVC balloon occlusion, the device is deployed, as you see here, in a relatively rapid fashion, and it's clear how helpful the CT fusion is in order to keep the branches, here you see the first branch, in a good position to the target vessels. Then the trigger wires are released and the dilator is removed, and the first branch that is connected is the branch from the right common carotid artery, connecting the innominate to the first branch, as you see here. And it is deployed without any rapid pacing or balloon occlusion, just in a standard fashion. And after that, the common carotid artery is surgically occluded. The next step in this repair is, in order to address the second branch with a steerable sheath, is using a preloaded catheter from the third branch to access the second branch, snare a 4-meter terumo wire in order to create a loop that supports a steerable sheath which is positioned in the ascending aorta, which you see here. This steerable sheath allows us then in an antegrade manner to access the left common carotid artery, which is here shown in an angiography, to pass a Rosen wire and to deploy and position a second bridging stent to the common carotid artery on the left side. In this case, it's a Viabahn balloon expandable graft. As the third target vessel, we again use the preloaded way to the third branch, which you see here. And this is a Merit Rhapsody self-expanding stent, which is a little bit rigid introduction system, as you can see here, but with some tricks, we can get it into a good position so that it offers a good seal in the third branch. And in the end, after ballooning, etc., we see a good result, and the final angiography offering perfusion to all 3 branches, and you see that the distal component already is in place. Before I stop my presentation, just to show you the end result of this case, where the patient also received a 4-branched endograft for the abdominal part, you can see the patient recovered again well and made a good recovery. To conclude, full endovascular artery repair with 3 branches is feasible, and steerable sheath access, as in the thoracoabdominal aorta, can reduce the access trauma. Thank you very much for your attention.
Thank you, Tilo, for this impressive presentation. Dr. Ahmed.
Thank you very much for fascinating cases. I have a question regarding the first case in which you showed us the type 1A and B endoleaks upon which you managed by embolizing the intercostal arteries. And my question is, how safe is it to embolize many intercostal arteries without jeopardizing the spinal cord blood supply and to be fear of having post-operative or post-procedural paraplegia? This is question number one. And the question number two, also it's very fascinating to make totally endovascular repair of the 3 arch vessels. But is there any comparative study regarding the arch debranching and endovascular repair of the arch without doing a totally endovascular repair? What are the benefits of doing this? Thank you.
These are two very good questions, and thank you for those. So to the first question of the embolization of the intercostal arteries, I agree with you that all occlusion of intercostal arteries carries a risk of spinal cord ischemia, and we prefer to do this in a second stage, as it has been shown that staged coverage of intercostals reduces spinal cord ischemia rates. So spinal cord ischemia, intercostal artery occlusion is never without risk, but it is required in order to treat the thoracoabdominal aneurysm. I cannot put a number to it, what the risk is, but I would think that this patient carried probably a risk of 5% permanent damage to the spinal cord, which is necessary for the treatment. Otherwise, we probably shouldn't treat at all these kind of patients. And the second question, let me remember. Can you give me
about arch debranching surgically before doing?
Okay. Yeah, that's a very good. That's a really good question. I can tell you, in the majority of cases, we still do arch debranching with the left common carotid to left subclavian artery bypass in order to make the procedure less invasive and less demanding and less time consuming. But then there are certain situations where a 3-branched is a good option. That is when there's a good landing zone in the left subclavian artery. And for instance, when we already need to do debranching on the right side in case of chronic dissections where we cannot land in the innominate artery. So I'm not a very strong proponent of arch endovascular repair has to be 3 branches. I think a 2-branched version is also a very good option.
Let me ask you, Tilo, about the advances in the use of steerable sheaths for these complex cases with arch stent graft, and how these steerable sheaths make cannulation of supra-aortic vessel cannulation easy and feasible with less risk. Can you highlight this point?
Very good question, Ahmed. Thank you. So to be honest, the steerable sheath used in this area is not really easy, but it is feasible. So one of the limitations is that the current steerable sheaths don't have a appropriate length, because they usually have to be 90 centimeter long, including a 15 centimeter handle. So you have to use very, very long devices. That's why we use the VBX as a bridging stent, which is the only one that has 135 centimeter of scaft length. So it's not really easy, but it is possible. And in cases where this allows us to avoid a bilateral carotid cut down, which is associated with significant bleeding risks post-operatively, that's where we use it.
Thank you, Tilo. Let us go to Mansoura University
Can I ask a
Cardiovascular
question?
Center because they were in place and they need us to be there. If you have time, Tilo, please keep with us. I know that you have busy scheduling.
Thank you very much.
Can we transfer to Cardiovascular Center, Mansoura University, Mr. Ahmed?